Hello, everyone. I'm Saad Omar. I'm the inaugural director of the Yale Institute for Global Health. I'm really delighted to welcome you all to this event of the Global Health Conversation Series. In addition to YGH, which is our more sort of popular name, the abbreviated name of the Yale Institute for Global Health, today's event is co-sponsored by the Walker Fund at the Macmillan Center at Yale. Well, as you know, that the COVID-19 pandemic has really catapulted the CDC to the center of attention with daily news stories and everyday conversations among the general public health. Who would have thought that there would be memes, a lot of them positive, but not uniformly so, on Instagram about the CDC, or there would be TikTok videos, covering and talking about the CDC. Well, with the focus that is there on this government agency, today we will reflect on the work of the CDC, including how this agency can evolve to keep pace with the health challenges the US and the world faces, and what it means to have the microscope of the public on this institution's decisions. It is my sincere pleasure to have three distinguished guests joining us today, all of whom are former directors of the CDC and are and esteemed public health professionals. And I will introduce each of these panelists in a second. Before I get to that, I just want to say that one of the directors is having some technical difficulty in joining. So Dr. Tom Frieden may join in the middle. He may not be sort of present at the beginning of this session. So starting with the introductions, Dr. Jeff Copeland directed the CDC from 1998 to 2002, and was a 26-year veteran of the agency. He has worked on virtually every major public health issue, including infectious diseases such as smallpox and HIV/AIDS. In fact, when I was leaving Emory, where I was before coming to Yale, he gave me a bifurcated needle from the smallpox program. I don't know if you remember, Jeff, as a gift, as a souvenir. He also worked on environmental issues such as the Bhopal chemical disaster and the health toll of tobacco and chronic disease around the world. Currently, Dr. Copeland is a senior strategic advisor for what's called CHAMPS, which is a pioneering program in assessing the causes of childhood mortality around the world by using innovative methods such as minimally invasive biopsies and other similar approaches. And he's also the PI of the International Association of National Public Health Institutes and the Global Health Institute China Tobacco Control Partnership at Emory. He founded the Emory Global Health Institute in 2006 and served as the Institute's director and as Emory's vice president for global health until 2021. But I would say the coolest thing about Dr. Copeland is that he's one of our own, and he did his BA from Yale. And I forgot, which college were you in? I'll ask you.
Stanford.
Okay, good, wonderful. And served on Yale's Board of Trustees. And he currently serves on the Yale Institute for Global Health's advisory board, and we have and continue to benefit from his public health wisdom. The second CDC director that I'll introduce is Dr. Julie Gerberding. Again, I'm going in sequence of their sort of chronological sequence of their service. Dr. Gerberding was also a CDC director in 2000s. I actually have, from 2002 through 2009, where she led the agency through more than 40 emergency responses to public health crises. She's the executive vice president and chief patient officer at Merck, where she's responsible for patient engagement and advocacy, population health, and and similar tasks. She joined Merck in 2010 as president of Merck Vaccines and has just recently announced that she'll be retiring from Merck in May 2022, when she will become the chief executive officer of the foundation of the National Institutes of Health. That's a very cool job, I guess, in this scenario where undoubtedly, like other public health agencies, NIH will evolve after and during the later phases of the pandemic. And there is a lot of excitement around new leadership at NIH. So in that function, I think I couldn't think of anyone more suitable to be in that role who has both government and industry experience. The third director we have as our guest is Dr. Tom Frieden. He was the director of CDC from 2009 to 2017 and had, look, CDC director is a cool job, but I think in public health, the coolest job is the commissioner of New York City Department of Health. I don't think it's one job that is never boring, I guess. And so his work made New York City's TB program and overall health departments models for the world. And his initiatives around tobacco, around trans fats, around some of the other causes of ill health were pioneering and were bold and frankly controversial at the time, but in retrospect, very well vindicated. He established before that effective programs in India and improved morale, effectiveness, and impact at the CDC. He is now the president and CEO of Resolve to Save Lives, an initiative to prevent epidemics and cardiovascular diseases worldwide. He's a national and global leader who has improved health in the United States and around the world, and is one of the world's top experts in TB, tobacco control, and health policy and administration. So, this is a highly abbreviated version of each of our guests' introduction, but it really does give me pleasure to have them come here, albeit virtually, and engage in this discussion. As I said, it's a forward-looking discussion about the CDC and U.S. public health. So the first question I have, and the way this goes, is that I will ask a set of questions, and then in the second half of our conversation, we will field audience questions, etc. So the first question is a common question from each of you, and we'll go in the same sequence, starting with Dr. Copeland, going to Dr. Gerberning, and then Dr. Frieden. The question, Dr. Copeland, is that when you were, starting with you, when you were the CDC director, what was the biggest challenge you faced, and how did you respond? And what were some of the lessons learned from that experience that are particularly relevant now and going forward?
I hope we have a couple of hours to discuss that. The biggest thing, and Dr. Gerberning knows it as well as I am, was heavily involved, was the anthrax attack. The first time an attack of that scope and size had been unleashed in the U.S. And even though one might not, the number of cases and the number of deaths doesn't compare with the current pandemic, nevertheless, it was a traumatic event for the country. It was newspaper coverage, front page every day for weeks. It had CDC working very closely with security agencies, in particular the Federal Bureau of Investigation, the FBI. And the scary thing about it, at least to me, was not only were we dealing with a difficult, lethal microbe, but we had human intelligence behind that microbe. And makes it a little different from naturally occurring events. And in addition, it didn't take many cases, nor much effort on the part of the perpetrator to have the country in a chaotic, unstable situation around this as a threat. So that was an unusual, thank goodness, unusual event, and one that seemed to grind to a halt of its own accord. So, because when we basically had finished our investigation and we're still involved in parts of it, nevertheless, there were no new cases occurring, nor signs that the perpetrator was off doing other things. It reminds me, however, of a common question all of us have been asked at some time, which is, are we prepared? For what it usually isn't modified. It was, would you say we're prepared for public health threats? Well, it really depends on prepared for what. Are we being prepared for 5 letters in 5 mailboxes in a couple of locations? Or are we prepared for hundreds of letters and hundreds of locations where they're deposited and an ongoing threat that doesn't stop? There's a big difference in response and in the threat that poses to many aspects of the country's existence. Things learned from that. One is that you can't be over-prepared, that what strikes next may have characteristics that are very difficult to either categorize, explain, or control. And yet we need to be as prepared as possible. But that includes a work, and we'll get into this more, that in something of a colossal nationwide and then worldwide threat, having a workforce that's adequate to meet that and the wide range of skill sets that are needed for it is difficult. And very few places have anything approximating such a workforce. In addition, preparation includes mock exercises, role playing, and those that were held were very helpful and very useful, but that needs to be an ongoing feature. In terms of other aspects of it that we can learn from, the need for a skilled, talented, dedicated workforce emanating at the grassroots level in counties and small cities and townships and moving up through state health departments and then federal governmental institutions. That interface between those different levels is crucial in control of an outbreak of almost any kind.
Wonderful. Dr. Gerberding?
I'll just build on Jeff's comments. And by the way, hello from South Dakota. I am having a little bit of connectivity challenges here in the hinterlands, so please forgive me if I'm fading in and out. I think our tendency is to gravitate toward the infectious disease emergencies or these urgent public health crises, and I'll say a bit about that. But I actually think the hardest thing for me as the director was balancing those urgent imperatives with the other health threats that plague people on an ongoing basis. We came into the CDC in the middle of an HIV pandemic. We are dealt with an obesity pandemic that continues to be a global health threat. So I think the challenge for leadership is how do you make sure that you don't neglect the important issues that are longstanding and go so far in the direction of the acute crisis that you really create a public health system that can't fulfill the entirety of its mission. And that's not just a challenge at the CDC. We are a system. We have to include our states, our counties, our local, territorial, and tribal health departments in this conversation, as well as multiple partners outside of those organizations. And when we're talking about preparedness or challenge, it really, I can't think of a single challenge that we experienced at CDC that wasn't also a challenge on the front line of public health somewhere else. So that's a really hard situation. I'm sure Tom will have more to say about that because he's been on both sides of that equation. But for me personally, I think clearly anthrax was an incredible stress test, but it helped us get ready for the next big threat we faced, which was the first SARS outbreak in 2003. And fortunately, CDC really, I think, exemplified a learning organization under the leadership of the National Center for Infectious Disease, as well as Dr. Copeland, when we established a whole array of after-action reviews with virtually every set of stakeholders that you can imagine, from law enforcement to hospitals to college presidents and so on and so forth, really to learn and listen to the panoply of stakeholders that needed us to be supportive and helpful and provide some coordinating leadership. So that outbreak, when we were walking into it, was very ominous, because if you recall, the mortality rate from SARS was about 10%. And we were seeing it globalize overnight in the respiratory tract of a handful of travelers that had all stayed in one hotel in Hong Kong. And from there, nosocomial transmission, as well as some significant community transmission, in some cases mysterious community transmission, for example, in a residential facility in Hong Kong, where I think to this day we don't exactly know how the people were infected. So many examples of how we had to learn on the fly, make decisions with insufficient data. And when I've been watching CDC and the public health system in the context of our current pandemic, I think one of the biggest lessons I'm reminded of is that what you see on the outside and what's above the fold on the newspaper does not tell the whole story about what's going on across our entire public health system. There are absolutely heroic decisions being made, heroic data being gathered and translated and promulgated, guidance documents that are addressing some of the most specific needs that, again, don't always make the controversial front page, but are actually important to different sets of stakeholders. So as we talk about how to make the CDC or how to make our public health system stronger, we should also make sure to be mindful of the strengths that it does have and make sure we don't inadvertently diminish those while we are trying to solve some of the longer term structural, financial, and workforce challenges that we face in the modernization imperative, I think is how I would put it. So I'll stop there. And as I said, I'm sure Tom will be able to balance the CDC view with the New York City local view.
Thanks so much. Well, I agree with everything both Dr. Copeland and Dr. Gerberding have said. And I really appreciate the last point Dr. Gerberding made, which is it's easy to criticize, and it's often hard to do better. And it's very important when we're thinking about public health, meaning the public sector's public health program, to realize what are the constraints they work within and what's the art of the possible in terms of public health. I'm going to mention two challenges that I faced. One was the Ebola epidemic, and that was massive. I remember at one point speaking to the incoming EIS officers, and one of them asked, "What percentage of your time is on Ebola?" And I said, "Well, I don't know exactly, but it's certainly above 90%. And that was the case for months. When there was a case of Ebola in Lagos, Nigeria, that was the scariest moment of my 7.5 years as CDC director, because if it had gotten out of control in Lagos, it would have been all over Nigeria, all over Africa, not just for months, possibly for years, and not just killing people from Ebola, but shutting health systems. So I remember putting my hand on the shoulder of one of our top control experts and saying, "You will be on the flight to Lagos tonight." And he was. And we pulled all of our polio staff and a number of other staff there. And the team did a fantastic job. The Nigerian team did a fantastic job based on really the polio infrastructure and the field epidemiology workers. And they stopped the outbreak. They stopped what would have been a huge disaster. A couple of months later, we had a case in the US that wasn't promptly diagnosed. We had contacts, one of whom flew, and it was a real mess. We came in for heavy criticism. Not every decision we made was perfect. Absolutely, we made mistakes, but we made the best decisions we could based on the data that we had. And I think that the information that we conveyed and the lesson that we learned is that communication is absolutely essential. Tell people what you know, when you know it, how you know it. Tell them what you don't know and what you're doing to try to find it out. And give them practical, concrete things they can do to protect themselves, their family, and their community. These are the principles that Jeff and Julie wrote and we inherited as the principles of emergency health communication. Be first, be right, be credible, be empathetic, be respectful, give people practical, proven things to do. Because if you don't give them practical things to do, they will do other things that aren't very practical.
Yeah.
The second broad area, it was tobacco control. And here, this is what kills the most Americans. And we were able to run hard-hitting ads. We were not able to get the Food and Drug Administration to take some of the regulatory action we wish they had. But if I can, I'll just end with 4 big lessons. One, speed is really important. In Ebola in Liberia, we established something called the Rapid Isolation and Treatment of Ebola, or the RIGHT strategy. And we found that if we could intervene in days, hours and days, instead of days and weeks, we could stop every chain of transmission within 3 generations, within a month or 2. If we didn't, it might go on for 6 or 12 months. Second key lesson is flexibility of funding. CDC is hamstrung, 150 different budget lines. I had literally 20 times more flexible dollars as New York City Health Commissioner than I had as CDC Director. And when Ebola hit, it happened to be the end of the fiscal year, and we actually had to borrow $3 million from another agency to pay plane tickets because we didn't have that kind of flexibility. Third is the global nature of public health. A risk anywhere is a risk everywhere. We can't pull up a moat, and certainly COVID-19 shows that. And fourth, the importance of policy change. Policy change is the royal road to progress. And whether that's clean water and clean air, or that's rapid data modernization, or that's any policy aspect of public health, it's very important to keep that in mind. I'll stop there.
No, thanks. This is wonderful. And I was just going to say that, the playbook y'all wrote, we teach that playbook, communications playbook. It's out there. And I wish this was more widely used, especially in this pandemic, at various levels. I will sort of switch things around a little bit because we're getting a bunch of questions, a lot of questions. So I will go to an audience question, and Dr. Copeland, this one is to you, and to continuing some of the points that Dr. Frieden brought up. What do you think about, how do you work with CDC's Washington DC office to advocate for and enact public health legislation or public health policy? Obviously, CDC is an Atlanta-based organization. For those of us who don't know, it's very much enmeshed in the overall fabric of that city, etc. Obviously, it's a federal entity, but it's not a Washington DC entity, which frankly has been leveraged fairly successfully by a lot of leaders by making sure that there is a bit of a separation between the political arm of the U.S. government and the sort of the technical arm of the U.S. government. But setting that aside, that has another dimension about the sort of the DC office and how, what are some of those dynamics that can be leveraged? Dr. Copeland?
Thanks. There's been a lot of discussion of this over years, that, that it's bad to be away from DC because that's where all the political action is. Other person says it's great to be away from DC because we're immune from some of the politics that goes on there that's not helpful to us. The bottom line is you need both. First of all, if you were to want to move CDC somewhere today, you'd have a lot of bricks and mortar on your hands as to where to put it. And you'd be losing an extraordinarily talented workforce that is in place, and I think largely thrives by being a bit more distant from the world of politics. Having said that, leadership at the center and in the Department of Health and Human Services needs a close interface with CDC leadership. So there's a Washington office, and I think it's developed considerably over the years and makes a big difference. That their folks that are there have often been on the Hill before, know a number of people, and can cultivate a bipartisan approach to health and public health that's really vital if we're going to be continuing to improve our outcomes versus the various diseases that threaten us. Having friends in the legislative branch, of course, in the executive branch, are really important. And And that means they need to be knowledgeable about what we do and knowledge about public health. I think one of the problems we are dealing with right now, which is an unfortunate drop in respect for science in general, for scientific institutions, for the people that work in them, is disastrous for the well-being of the country. That's not where growth is. And growth and discovery and application are what counts. So and for that to work, the relationship with government isn't going away. We need to inform and encourage engagement of elected officials in what we do at the state and local and federal level, and to have them as partners moving ahead with all the different pieces that my colleagues have described, whether they're chronic diseases, non-communicable, environmental, occupational, as well as infectious. All those need the support from the Hill. The folks in Atlanta do better when the folks in Washington, the elected officials and the appointed ones, in having respect for public health, enthusiasm for what it's accomplished and contributes, and become partners with us. And that's occurred regularly over the decades of the CDC. Some elected officials in the House and Senate, and take such pride in what CDC does that they've played a role right alongside us in getting things done. And I think we'd all love to see partners like that again.
Wonderful. Dr. Gerberding, when you were the CDC director, there was a pretty substantial reorganization effort to improve sort of the functioning of CDC as an overall organization, but with a specific focus on improving preparedness from various threats. Nearly two decades later, and in light of recent events, any thoughts on further restructuring or any lessons that you can look back towards that can inform CDC's future and broadly public health's future in the US?
I'll just start by saying something that Jeff brought up in the beginning, and that is that anthrax taught us a lot. It taught us scale. It taught us, intense pressure and visibility. It taught us the globalization. A lot of people don't know that some of the mail that was contaminated with anthrax spores ended up in the diplomatic courier pouches that went to a number of embassies around the world. That was kind of out of the news, but something that was certainly on our mind at CDC at the time. And so, the sequence of events, it is hard to go back in time to 9/11 and then the anthrax attacks that followed shortly after and recall the mindset. We had no reason to not believe that anthrax was somehow related to the 9/11 attacks. So that did flex the apparatus of public health as well as our entire government in a direction that was much more focused on the what if scenarios. I think the good part of that is that we did make some substantive investments that have had staying power and have led to broad improvements in our public health preparedness across our network. But the challenge is sustainability of effort, investment, and basically leadership intent. And we often characterize these decades as periods of boom or bust, or complacency to crisis to complacency to crisis. So, restructuring is not the solution to anything that I've ever experienced. I think that sometimes restructuring can result in efficiency or can create opportunities to bring in a different kind of talent or rearrange people. But basically, the kinds of things that are really necessary to build a prepared nation are some structural issues, certainly budgetary issues that Tom has already mentioned. And I think authorities also come into this. You may not realize that basically CDC has essentially no authority to determine what happens in a state or a community health department. And yet to really have an effective cascade of protection, whether we're talking about emergencies or chronic problems, we have to have a much greater degree of harmonization integration of our data systems, which currently are, about as integrated as a children's sandbox. And we really have not been able to solve for these foundational changes that are necessary to truly modernize, not just CDC, but the whole network that has to come into play. We saw this in the pandemic, where we couldn't get in real time the hospital information, or when we couldn't really get vital statistics data. And I'll refer you to other resources on that, but the failure to be able to report the mortality from the pandemic is not because people in Atlanta didn't want to do it. It's because the whole network has to contribute data in a uniform way. And we had, until the emergency declaration was called, we had no authority to do that. So there are some very specific authorities, and we have to start considering, are we at a point in our evolution where we need a national public health system, not a network of 3,000 plus independent entities that cooperate, but not necessarily in an efficient or timely manner?
Yeah, no, I think it makes a lot of public health sense to at least think about this. Obviously, it will have pretty substantial legal and even constitutional implications. Because
yeah, perhaps the 10th Amendment would come into play in this conversation, but I think there are still some things we can do because we all want the same thing. And when it's the right thing to do, we have to think, then how do we reshape policy so that we can do the right thing?
Yeah. This is wonderful. So Dr. Frieden, the next question from you again, it's from one of the reporters in the audience. And they want to know, do you think the use of Title 42 is still justified in the current public health context? And is it appropriate now that the order has ended for unaccompanied minors for it to continue to apply to families and adults arriving in the US borders?
Well, I don't want to comment on the policy issue there. I thought you were asking about Title 42 hiring, which is a mechanism by which CDC is able to pay competitive salaries. And that certainly needs to continue. But that's a hiring policy. I think the broader issue is how do we in public health keep faith with the American people? How do we make clear that the decisions that are being made are made based on both the science and the policy implications? I think there's kind of a misunderstanding of certain things. When you say follow the science, yes, the science will lead you so far, but the science ends where a community makes a decision. And that decision might be made differently in different communities. So let's take COVID as an example. At the same level of COVID transmission in one community, that community may decide, we really are concerned and we're going to shut restaurants, bars, and churches and other houses of worship until it gets to this level. Another community may decide, our churches are so important to us, we're going to keep the churches open. Another community may decide our bars are so important to us, we're going to keep those open. But fundamentally, it's not just a question of science. It's a question of science and policy. And CDC can inform the science, but CDC doesn't set policy. It's the US government that sets policy. And I think if I can reflect on what's happened over the past 5 years, there was an inappropriate interference with CDC science in the prior administration, to the extent of folks at HHS writing things on the CDC website to be posted as if they were CDC documents. That's really inappropriate. That's, I said in one forum, that's the equivalent of writing graffiti on a national monument. But somebody says, if you write graffiti, and corrected me and said, if you write graffiti on a national monument, people know it's graffiti. Here, people didn't know it was graffiti. So yes, there's certainly an inappropriate policy involvement, but it doesn't mean that CDC sets policy. CDC informs policy with science, and then a policy decision is made. If that policy decision is so divorced from where the science leads, people at CDC may object, they may quit, they may leave, but generally the way policy decisions are made is there's a give and take, and then a decision is made, and then people get on board to implement. But for the specific issues with immigration, I think we need to see more rapid change with things like travel guidance. The issues are tough. These are tough issues. I can tell you when Ebola, there was a case in the US, second case in the US, it was October 2014, the height of the midterm elections. It was highly politicized, calls for travel bans, very, very difficult to work rationally in that environment.
Yeah, no, I think that's a really great point, Dr. Copeland. I know that you have worked extensively around the world, and you have engaged with collaborators in China fairly extensively, and in this current environment, which is increasingly antagonistic between, there's no other way to describe it, between these two great powers. What are some of the implications of this kind of friction on global health, and what is the way forward? And both in the context of this pandemic, it really sort of surprises me that the US, the engine of scientific research and innovation, and China, the engine of manufacturing, have this non-alignment of mutual self-interest, it seems, or when it comes to collaboration around this pandemic, irrespective of what else goes on in terms of their own sort of domestic and foreign policy priorities. Any thoughts on that?
Yes. CDC has a history of globalization, if you will, of worrying about diseases that arise in a different part of the globe and are a threat to spread, and that there's value in having a working relationship with every geopolitical entity around the globe, because you don't know where things are going to start or where they're going to end up. And I think our philosophy, there's no written Bible on this thing, is that work with people who are like-minded with us and who have something to gain from making improvements in health and healthcare around the world. And whether in past decades it was the Koreas, it was Cuba, it was Russia at different times, et cetera. But in terms of interface with China, we worked closely with them for 30 plus years. And we've worked with people who have every bit the same sincere concern, desire to improve their health of themselves, their families, their communities, their neighborhood as we do, and have things to offer us that improve what we do, and we have things to offer them that improve what they do. So there are wrinkles in this. We're not immune or oblivious to what's going on around. And that's unfortunate. There's more to be gained by these two great powers than not. But that's well beyond our tasks or responsibilities. We can only do what we work in. And when it comes to working in public health, we have a long track record of working together, coming up with solutions to problems, improving the health of people's there and improving the health of people's here. But for the next pandemic, if we go into this thinking there are enemies, or they're hostile to us, or we're hostile to them, that may be true in some political layers of the fabric of life. But in terms of scientists, public health workers themselves, many have been here. We know each other's families. We work together. We're not naive. We know that problems can go on even in these settings, but we stand to lose much more than we stand to gain if we don't find ways to work together. And it will pay off soon or later, but it pays off to have these common partnerships in public health.
So, Dr. Gerberding, you have a unique vantage point. You have led a premier, or the premier in this country, public health agency, but also have been in the corporate sector pretty, for past several years. And one, issue, I know Merck is not engaged in those debates, But one issue has been global vaccine equity. Any thoughts on how we ensure that in the next pandemic, we build systems and we build public-private partnerships that ensure global equity in vaccines, and I know Merck has made certain commitments of making some of the treatments available earlier on through technology, proactive technology transfer, et cetera. But broadly speaking, rather than sort of from the vantage point of a single company, what can be the structural triggers policy makers can put in place so that we have a more equitable response in terms of vaccines and treatments the next time around?
Yeah, I'm really worried about it. I don't think it's going to be an easy solution set. What we have observed in the pandemic is well-intentioned statements and commitments that fall by the wayside when the reality of the urgency of the national demand takes precedent. We've certainly seen that in the countries that are making vaccines. I think perhaps one of the most poignant examples was Serum Institute of India, who had promised a significant number of doses to COVAX, the international consortium, to try to improve access to vaccines. And then the Indian government made the hard decision that with the Delta outbreak there, that they had to prioritize the allocation of that supply locally. There are some who believe that having many more sites of vaccine manufacturing in many more countries around the world would be part of the solution. And I don't disagree with that. But I'm very familiar with the scarcity of the resources, both human as well as technical resources necessary to manufacture a vaccine. And I'm also well aware of how hard it is to do it. If it was easy, we would have solved it a long time ago. All you have to do is look at the situation, not in an international setting, but in Maryland, when Emergent Biologicals was unable to successfully produce the Johnson & Johnson vaccine without encumbering several quality issues. So this is an area of science that's not for the faint-hearted. Over the long haul, we do need to have a more global network of vaccine supply, and I hope that the platform technologies will make that easier, although I'm not too optimistic that will happen fast. People are naive in how they assess the probability for that. But I also am concerned that our international institutions are not strong, and we need global leadership from the have countries to be inclusive of the have-not countries, so to speak, and much stronger commitments through the G7, the G20, the governmental alliances. And I would like to think that one of the lessons we've learned is that we are only as safe as the world is safe. And so it's an enlightened self-interest to try to do more to create an equitable vaccine solution. But as Tom and Jeff have both said, we're also well aware of the politics, particularly in an election year or in a government transition period. So these are really, really difficult problems to address. And it's not just a problem in a pandemic. We see this problem for more mundane problems as well. One of the places where I think we may be able to learn some lessons is from the Global Fund, as well as in its intersection with the World Bank. That part of the opportunity here is to leverage financing so that we create the mechanisms and the pull to be able to require this kind of global access. And the last point I'll make, because I feel so strongly about it, is that as we're seeing vaccine supply improve, certainly not where it needs to be, but certainly improved, it isn't just about the number of doses. It's about the systems and the ability for people to establish immunization programs, which in most parts of the world, there is no such thing as an adult immunization program. So to suddenly flex and try to immunize, not infants, but adults and teenagers of multiple ages, that's a heavy lift in a crisis. So if we're thinking about how to improve supply, we need to probably make sure we don't forget to improve the ability to distribute and trust the value of the supply that we are talking about. Lots of work to do here. I'm not trying to be pessimistic. I'm just saying that I think I have a pretty sober outlook on the lift that we need to get together and really try to support.
Wonderful. So the next question is actually from a former New York City Department of Health infectious disease epidemiologist. So naturally, I'll ask Dr. Frieden. Well, I can ask either of you, any of you. You were well qualified to answer the question, but I'll focus this one on you. And the question is, do you have any ideas about how to rebuild and reinforce the public health workforce post-COVID-19? There's a lot of burnout. There's a lot of despondence in terms of, despite a lot of hard work, there is a decline in trust, and we have to recognize that before addressing it. And so the other one part is the overall workforce from a health department perspective, from a federal agency perspective. But the other aspect of the question I would add is that often academic entities don't do a good job, and we have to be, or at least as good a job, and we have to be honest about, is to be responsive to the needs of applied public health. For public health, we shouldn't be in the business of creating facsimiles of tenured professors in the field of public health. We need to be in the business of creating consequentialist public health practitioners as well. And so any thoughts from that, because you've led a non-governmental organization, a health department, as well as CDC. What can we do better?
First, I think it's important not to either under or overestimate the problem. Yes, people are exhausted. It's been 2 years plus. In many parts of the country and world, public health has been quite literally under attack. And yes, there are a lot of people who are tired and have left the field or considered leaving the field. Already, it was an older workforce that was nearing retirement. That's why we created new programs like the Public Health Associates program at CDC to bring early career people into public health. I think, first off, we have to get the funding for public health right. This is crucially important. As President Biden said when he was vice president, you show me your budget, I'll show you your values. And that's why we're advocating for a health defense operations budget designation that would give people in public health confidence that it's not going to be that boom and bust, panic, neglect cycle. It's going to be sustainable funding, not just for their salaries, but for the programs that they're running, so that they can rely on the ability to start a program, continue it, and see it to improvement and progress. This is crucially important, I think, on one hand. On the other hand, I think all public agencies really need to think about how to make the job rewarding and safe for the workers. And that means that you are able to have and show impact. That gives people huge satisfaction. It is wonderfully inspiring to work in public health, but you have to be able to see the faces and the lives behind the numbers, because the people whose lives you save will not know that you saved their life. So you have to be able to be satisfied by the actual calculation of what the impact has been. You also have to continuously upgrade people's skills. We're all learning all the time, and that makes jobs more satisfying. And you have to have a work environment that is supportive and is able to contribute to people's sense of personal worth, personal efficacy. So I think, although there's a lot of media attention, and it's true that there are a lot of people who are tired and leaving public health, it's also true, as you know, that public health is very, very popular as an interest in colleges and universities, that this can be a time of public health renaissance, where we diversify the field, where we get into areas that are more effective, that we go deeply into communities to identify, as we do in all of our programs, what is the art of the possible in each community and in each time. And that becomes an enormously satisfying job. So I would say, by all means, we have to keep people in public health resourced, safe, supported, part of a broader network, nationally, globally even, and at the same time, recognize that it is a wonderful career with the opportunity to make a difference and help to improve, protect, save literally millions of lives.
No, you're absolutely right. And I sometimes say to my students that and trainees that the easiest way to avoid a midlife crisis or existential angst that a lot of people talk about is to go into public health. The job of public health can be frustrating, underpaid, tiring, but it is never, never, ever meaningless. It is always what you do has meaning. So I will sort of end, as we come towards the end of our conversation, and I'll say that we are getting a ton of questions. I have not even asked you a third of the questions we are getting because we have multiple streams. I see a question streaming in besides because we are going on Facebook Live as well, and so I'm getting sort of questions that someone is taking there from there as well, and then more direct questions as well. So I apologize to our audience for not getting to most of your questions, but I don't think anyone wants a 3-hour sort of program. But I will come back to the same format. I'll ask the same question from each of you. CDC is a national treasure, and yes, we need to recognize that it has taken a hit, a lot of it unfairly, but also a lot of lessons need to be learned. I'll tell you that we at Yale, the Yale Institute for Global Health, did the first survey in this National Survey of Attitudes in this pandemic on February 8th, 2020. And when we asked people, who would you like to hear from in terms of the response, the top one, not the president, not the NIH director, not before, well before Dr. Fauci became a household name, it was the CDC director. People did not know the name of the CDC director. And so that's the cachet, the baseline cachet CDC has, and we can return to that. The question I was asked most frequently to ask you is, each of you briefly, how do we restore trust in the CDC? So we'll go in the reverse order. So we'll start with Dr. Frieden, Dr. Gerberding, and Dr. Copeland.
I think the CDC needs to speak directly to the American people regularly from Atlanta, not part of a Washington or White House briefing. And trust is built teaspoon at a time and lost bucketful at a time. So it's going to take time, but success breeds success. And the more CDC is able to do great work and show the great work it's doing that it hasn't been able to show, I think it can steadily rebuild that trust. Julie?
I agree with Tom. I certainly think that the credibility of anyone at CDC is improved by communicating from the CDC and not from a political institution. But I also think that it's important to realize that the CDC is not convincing the world that the director is science-based or even that the CDC is science-based. I think we need to reflect the public health system as a whole. And so in addition to having the director, who I think our current CDC director is an outstanding spokesperson, I think it's important that we hear directly from the scientists as often as that's possible, that they're standing on the podium as information is being communicated, that they address the specific scientific questions. But I also think it's important that other public health leaders in our network are also part of the conversation. So it doesn't look like something has come down from the mountain and is being disseminated to the valley, but rather that our public health system together is strong. We're on the same page. We're collaborating and coming up with the interpretation of the science, but also, as Tom said earlier, the practical matters And that when we stand together, we can also explain why maybe we're going to do one thing right now in this community, and a community over here may be in a different situation or have a different judgment, and that's okay. We're still all starting from the same platform of science. But it will be a long slog to build the credibility of the CDC back up. And I think that's where all of us who are stakeholders in this need to help. I think we can endorse the things that have gone well and try to be helpful and constructive about the things where we think some improvement might be useful.
Dr. Copeland?
Yeah, just continuing what Dr. Gerberding was saying, at the best times in public health has been when we have robust local and municipal and state health departments working well with federal partners. And that's fallen apart a bit. And the need for commonality of interest and a visible partnership right through the system from grassroots to CDC director needs to be reinstituted in a way that people see it, understand it, and value it. The point has been made that there's a number of things went wrong in this investigation and probably will into the future. We're dealing with a largely unknown scientific entity, have made great advances in the course of it. But as one ventures ahead, we're not batting 1,000 in this thing, nor will we ever. I think the kind of attitude nationally, and it's not shared by everyone, obviously, nevertheless, takes, I think, an unfairly critical look at CDC in a way that doesn't serve any of us well. And if there's bathwater that needs to be thrown out, fine, but be careful what you're messing with in the institution. The institution has more talented, brilliant, contributing, scientifically minded people than any institution in the world, and that includes distinguished schools of public health at universities. And it needs to be nourished, and it has to be seen for its good aspects. I think attention is going to have to be paid towards funding, and that doesn't mean cutting funding. It means providing sufficient, predictable, flexible funding, again, from the grassroots level right up. The people in the field need to be working closely with CDC and vice versa. CDC needs to be listening to folks in state health departments, and always has in the past. Workforce needs to be improved, new skills, focus on data and analytics and communication. And with it is needed better pay and incentives and increased diversity in the workforce. It makes a difference in improvement of programs and outcomes. The data issues are real. That they couple with the science, as Dr. Gerberding indicated and Dr. Frieden has demonstrated over and over again in his career. But data drives things, and we need some common measures. It's really inconceivable that we're unable to get common measures from state to federal. This undermines what we're trying to do, and that needs to be corrected. Political influence has been mentioned. It can be good or it can be bad. Let's try to play out the good parts and value of politics in what we do. Communication is extraordinarily important. CDC needs a top quality lead in that, and an office that is 21st century in delivering messages, experts in social media, et cetera. So things, sure, this is an opportunity to improve, and a crisis like this maybe gets something much stronger at the end. We certainly hope so. I think we are still in the midst of a pandemic. Going to the beach and not wearing a mask, being in close quarters, lots of things are not history. They're not part of the past of this pandemic. Unfortunately, they're still part of the pandemic. So there'll be an ongoing key role for the likes of us and other people in public health and for its institutions in the more of those institutions can do their mission, the better off everybody in this country will be, and potentially in the world.
Thank you. With that, I'll close our session, and I want to thank all three of you for being here and engaging in this conversation. Hopefully, next time around, we'll have the pleasure of hosting you either individually or together as well in person. And you'll get the big benefit of being in person is that you get to interact with the most inspiring and smartest members of the Yale community, which is our students and early stage faculty. So with that, I'll close this conversation, and I'll remind our sort of audiences that we, stay tuned to the next conversation series event, which is likely to be equally exciting. So appreciate all three of you and everyone else who has attended, and those of us and members of the YGH team that helped make this conversation series possible. Thank you.
Thank you.
Thank you. Thank you very much.
Take care.